Okay, so thanks again. I'm really pleased to do this. I'm going to keep a timer on myself because I can talk, as many of you know, for ages. I'm going to be talking about oncofertility models of care, and I've sort of divided it into describing the barriers to oncofertility care, describing the essential components of care, and describing strategies. And how I'm going to do it is talk through phase 1 to 3 of some studies, and 2 and 3 were international collaborations, and then talk about the vision for phase 4, which is implementation. So why are we interested in models of care? We know that fertility preservation is one of the top 5 unmet needs, and that's not just for our childhood cancer survivors. It goes across our adolescent survivors. It goes across our adult patients of a reproductive age. And as patients go into that post-reproductive age, it is still a highly unmet need for patients. So we know it's important. We know that oncofertility should be integral to the care that we're providing, whether you're in a pediatric or an adult cancer centre, and whatever branch of fertility medicine you may be part of. Jen has just done a lovely presentation about guidelines, and there's 25 current international guidelines. And I think there's about 4 that I know of that are being developed at the moment, and probably others. So what interests me is that despite all of these guidelines, there's been slow, steady progress in improving oncofertility care. But when you compare it against some other guidelines for heart disease or antibiotics, we haven't implemented things as quickly as our colleagues in different disciplines have. So I wanted to try and understand why. So when we think about barriers, again, there's lots of different barriers, and I think we heard this morning that some of those are clinician-based, some of those are patient-based, some of those are institutional-based. And it's still very important that many of the patients we're reaching are patients who are more affluent, they're in metropolitan centres, and the patients we're not always doing the best for are underprivileged patients of a lower socioeconomic accountability, our cultural and linguistically diverse population, our patients in same-sex relationships. We have differences in costs depending on where we are in the country and the world, and we've done a lot of work more recently in the consortium with our low and middle income countries, and it's not surprising that the patients in those countries have exactly the same expectations when it comes to oncofertility care. So the first study we did was part of our consumer study, and in this study we were looking to develop our Australasian Oncofertility Consortium, and I've presented this work, so I'm not going to go through it again here. But at the time we had 13 different focus groups, we had 50 patients representing childhood, adolescent and adult cancer patients. They represented rural patients. On average, a patient travels 247 kilometres to see me. So we wanted to make sure that their voice was heard, and we also have representation on this group from our Indigenous patients. And unlike any other work I've done, these 50 patients have remained with the group and have been an active participant in all the research that I've done here, and we've got an increased number joining the group, and it's been a really important part, I think, of what we've done. So while we were developing the consortium charter, we wanted to identify those domains, we call them, that were valuable or missing from their experience of care. And our consumers, and consumers may be a very Australian term, but we really mean our patient advocates, and they were not only, not necessarily cancer patients, they may be parents, they may be partners. but in this case, these are patients. We asked them these areas, and they came up with these 8 different areas. So communication, documentation, and by what they meant by documentation was the documentation they received or the documentation their primary health caregivers received, not about what we get in the notes, but it's obviously connected. The decision and the support they received, what they perceived the training of healthcare professionals was, age-appropriate care, psychosocial care, the referral pathway between cancer and fertility and back to our survivorship colleagues, and then survivorship care. So from that, we asked our clinicians who take part in the registry that I'm part of the same questions, and they agreed broadly with these 8 groups, and they added 2 others, and that was supportive care for fertility preservation and ethics and legal. So in phase 2, we worked with an international group covering 16 countries. Until recently, I said 17. I forgot about Scotland being part of the UK. I think I was consumed with Brexit at the time. So, here we wanted to take what our consumers had said was important in terms of domains for a model of care and look at the literature. So here we did a systematic review. We had just under 1,300 papers that met the Prospero PRISM criteria, and we ended up with 261 papers that were included. So I'm going to go through these domains, and then I'm going to talk in the next page how we put it together with a competency framework. So, in terms of referrals, when we looked at the data, the referrals really varied. Not as many as you would expect were regularly or always referred from a cancer physician to a fertility provider. And you'll see that, while this was a systematic review over a 10-year period coming up to 2017, we could say that there's been some improvements from 15% to 54%, but our patients' expectation, certainly in our charter, was that everyone should be told and have the expectation that they're told about fertility preservation and should be offered a referral if they felt that it was important for them. So certainly an area we could do better. Factors that influenced referral. Well, we know that there were differences, that our male patients were more likely to be referred, that obviously our post-pubertal patients were more likely to be referred, and patients of specific tumour groups were more likely to be referred. So our Hodgkin's group and our breast cancer group have really done a lot of work to embed fertility preservation and survivorship into those protocols, and our brain tumour and sarcoma groups, as a comparison in the literature, weren't quite as good, and certainly the papers show lower referral rates. When we look at it, divide the data that we've got between patient characteristics and clinical characteristics, again, there were, some differences that are important. So from a clinician point of view, having a clinician who is knowledgeable, who understood about fertility preservation, who had a favourable attitude towards fertility preservation, who is female, and who had the opportunity of having the discussions more frequently, more likely to refer a patient. And as I said, being male and being between 20 and 34 were the patients who were more likely to be referred. So obviously we've got more work to do there. There were certainly lots of hospital factors which have an effect on referrals, so difficulty finding a facility, difficulty in terms of the ability to get care in an adequate time. And I think Jenna spoke very nicely about the holiday periods where there may not be as many providers. Having access to what we've called care navigators, so basically the support that will allow the coordination and the referral process, the ability to have checklists, whether they are IT-based, prescriber-based, or paper-based, to identify patients, the suitability of centres that actually saw a big enough volume to be doing this so often that they felt comfortable in doing it. So as a summary there, we know that referral pathways are important. They need to be integrated in standard practice. The time when you see a patient isn't the time where you should be calling to ask a colleague who the fertility or andrologist specialist is, and that slows things down. If you've got a referral pathway that's established, it helps, and certainly care navigation is part of that referral pathway. From a decision aid point of view, we know that there are a number of decision aids, both paper-based and IT-based, and those decision aids help patients to understand the options and make choices. And we now have the opportunity to have decision aids for both children and young adults and adult patients. In terms of benefits, they were reported very highly in terms of usefulness and satisfaction. Patients who used them felt that there was less decisional conflict in making decisions. There were trends towards higher knowledge. There was certainly lower regret in the months after cancer diagnosis and they'd made their decision. They were more useful in terms of engaging medical staff in discussions about fertility preservation, and patients who had decision aids were more likely statistically to be referred to see a fertility specialist. But there are some concerns. So the content and readability is obviously an issue for some patients. Parents often felt that they could be a little bit too technical. Patients sometimes find the information upsetting, and even more reason to have good care navigation and support so that there are people who can go through this. Thinking about health literacy and the reading age of these documents is important, and certainly the quality has been shown to vary. So we know they provide better understanding, they help make decisions, and they reduce regret. So in terms of types of communication, we know that there are lots of different types of communication, that clinicians tend to use verbal communication as their main way of communicating. Referral to written and online resources does occur though. That tends to be very varied. 60% of clinicians rarely or never gave any fertility preservation resources to patients. And so that's really important when we're thinking about our previous decision aids and decision making when they're not getting any signposts to additional information. And there wasn't consistent information in providing comprehensive information, which again, given that there's so much information and resources at this time point, is disappointing. The timing of communication significantly varied depending on the studies. Cancer survivors and our nurses believe that clinicians should initiate the conversation about fertility preservation. But you'll see in these studies, and they come up to 2016, where between 23 and 50% of the discussions were actually initiated by a patient or family member. And so, that might be about timing. It might be given a little bit of time. The cancer clinician may have raised it. It's always difficult when there's so much information to say in a consultation. But this is certainly the feeling from these patients that they had to bring it up. And when clinicians were asked, why they didn't have the discussion. There were some views that they didn't want to upset the patients. And that is an older paper, but still an important caveat for us to really try and drill down and understand. The quality of the communication was very mixed. We've seen just as many papers that show that patients were satisfied with the quality as the number of studies which show they were frustrated with the quality of communication they received from their clinician. So what role do clinicians feel they had in imparting fertility preservation and oncofertility information? Well, the majority of clinicians actually believed it was their role when asked to discuss fertility preservation, so that's important. But there's one study that showed 40% of clinicians thought that patients actually should bring it up if it was important to them. And again, that's the worry. Most people felt that it should follow soon after information about diagnosis, which is in keeping with the guidelines. And cancer, certainly some cancer patients that felt the information should be given by a fertility expert. So, here is, this sort of the compromise between having the knowledge to say that it's important, but also maybe not necessarily having the skills to be able to do it justice. From a patient point of view, patients very clearly want to receive the information. They want to receive it at diagnosis rather than hearing about it after, and they want the information to be clear. There were 3 papers that described difficulties experienced by healthcare professionals in terms of communication with professionals of the same specialty. And I've heard in this meeting when we've been talking with colleagues that, some challenges that we all have talking about fertility preservation. Difficulties in communicating with different specialties that you have to work with is also a theme, and again, a theme right up to 2016. And this is echoed by patient perspectives. Patients can see through this. When you're trying to phone up in front of them and find the fertility provider and you're being given the runaround, it's really clear to patients that there isn't a system and that people don't regularly communicate, and they find that quite frustrating. So, when we think about communication, we want it to be evidence-based. We know that patients want both written and verbal information, and we want it to be age-appropriate. And we're going to hear a little bit more about age-appropriate in a bit. And essentially, healthcare professionals need to be knowledgeable and comfortable providing the information. So with age-appropriate care, we really wanted to look in this review whether there was any difference between our younger patients and our older patients. And essentially, IWA patients showed really high ratings for the importance of this information, irrespective of what their decisions in the future are going to be about parenting options. They wanted the information to be detailed, but to be understanding, and like any adult patient who had cancer, they wanted to hear about the risks, the benefits, the side effects, and the success. And they wanted to hear it from people who had expertise, could understand them from an age-appropriate point of view, and they wanted also support. In terms of provisions of care, though, they felt that the information needed to be tailored by their age, tailored to their life stage, relationships and fears. So many of these younger patients haven't necessarily been sexually active, haven't been partnered, haven't thought or haven't decided about sexuality. So the information had to be given in that context and tailored to their personal stories. So, we had the papers where, a younger person is given a breast cancer resource because that's what they had in their service rather than a resource for a sarcoma. And so patients felt that was quite frustrating. And patients want to be listened to and want to be respected. That patients also want to hear about the future, but they don't necessarily want to hear it all at the same time. So coming back and giving them information is important. And this idea about health literacy and reading age is really important because they didn't want to be given too much information or information that wasn't clear. From a clinician point of view, there were conflicts. Certainly, clinicians felt a level of discomfort, difficulty, being embarrassed, being awkward in a parent's presence, having a discussion about fertility or sexual health. 2 studies reported a preference of clinicians treating AYA patients to discuss provisions without the parents being present. So what's the patient's preference with care? Well, more than half actually wanted their parents to be present. And as an adolescent physician, I see this all the time, especially in young people who are unwell, and there becomes the interdependence on your support system. And 44% preferred their parents not to be present during the initial conversation. So here you have a thing where communicating and understand that patient and that family is really important. Patients with partners reported that they wanted their partners to be present, and there were a study that showed that having the written information was not only important to the patient, but they used that as an opportunity to sit down and read it with parents. So really important for communication with that wider family members too. In terms of provisions of care, the majority of centres did not have a policy on the provisions of care when we looked at, specific service development. We found very little evidence of referral pathways being developed. While 75% of clinicians felt guidelines were needed in their institution, that, I guess is an important factor. We know we've got lots of international and national guidelines, but having something that really fixed to that patient, your own patient population, was felt to be important. And when we looked at the data on provisions of care, we're still seeing that many of the referrals are from academic centres. So really important to think about those patients that are in rural and regional communities. So when we think about age-appropriate care, we've got 3 highlights: needing age-appropriate verbal and written consultation, a choice of family or friends present for the consultation, and information relevant to the stage of life and lifestyle that patient has. So now moving to the clinician knowledge and training. Almost half of oncologists in one study were not aware of fertility preservation options for female patients. Now, you would hope that would improve over time. And you can see as these studies age, we are getting better at giving information. But even in current studies, there is still our oncology community saying that they are not having enough training. And I was really pleased to hear the earlier talk given about education. But, the fertility providers, in my experience, have always been happy to see our patients. So we still need to focus on our cancer clinicians to get the patients to the fertility providers. And certainly the literature shows that we need to be doing better in that area. Clinician comfort level was also an area that we need to focus on. Certainly our patients perceive that clinicians are sometimes uncomfortable or dismissive about their interest in fertility preservation, although some studies certainly highlighted that there are clinicians that have a high level of comfort, and the studies show that comfort level certainly improves the more often you have these discussions. And what was important to me is that in my practice, I couldn't do without the clinical nurse consultants that work with me both in the Oncofertility and my AYA service, and yet the papers are still showing a significant gap in our nurses and allied health professionals when it comes to oncofertility care. So it's really important that we continue to work on that area and ensure that we have a growing group of champions. What type of training is required? Well, we've heard that clearly we need better communication skills, and that not only improves knowledge, but it improves confidence that clinicians have. Online training has been developed, and we've got some wonderful examples of that here, and they have proven to be beneficial, especially when clinicians are time poor and are in rural and regional centres. So again, in terms of training, we have to cover not just knowledge, but communication, medical management, and psychological support and management. So what about survivorship? Well, we know there's a lack of understanding about, patients have a lack of understanding about fertility status in survivorship. A lack of importance has been placed on follow-up, and limited fertility follow-up depending which study is shown, and really depending on which centre you're in. Very low numbers of clinicians are checking the parameters of reproductive potential following cancer treatment, and I think it's disturbing, this study in 2016 saying that 72% of our cancer clinicians rarely or never check or inform their patients. In terms of information needs, I mean, this certainly overlaps the themes with what I've said before about communication and provisions of care, but patients want individual information about their fertility after cancer treatment. Many survivors have incorrect beliefs about the extent of their fertility problem, and it speaks to those patients who have low risk or no risk, who've gone through thinking that they have a higher risk, and vice versa. A lot of frustration about the quality of care and lack of continuity of care in survivorship. Frustration with a lack of planning for future parenthood, and increased anxiety. So in terms of reproductive survivorship, we've really got to be thinking about rediscussing fertility preservation, discussing options for parenthood, especially in those patients who may not have had fertility preservation at diagnosis and there isn't that opportunity. Discussing sexual function and dysfunction that goes hand in hand with fertility preservation, and thinking about health and prevention and hormonal management. In terms of medical management, there weren't any studies that met the Prospero PRISM guidelines, but certainly there is a need to consider that our cancer patients often have many other medical comorbidities as a result of their cancer diagnosis and tumour location. Many of our patients may be pancytopenic. Our non-malignant patients may have immunological, metabolic, or blood disorders that result in lower counts and lower immune systems. We've got to think about anaesthetics, not just the blood count, but thinking about the safety of the anaesthetic, what patients are like when they're laid down, what their blood pressure's like when they're instrumented. Thinking about the need for blood support before a procedure and following a procedure, the consideration for risk due to the tumour site. And the question that we get asked a lot is, when is it safe to start the chemotherapy? And we hear different things depending on the clinician involved. So we've got to be clearer with our recommendations. Documentation. Well, we know that documentation is really important, not just for our patients' ongoing needs to have information, but our communication with our colleagues, both at the time of fertility preservation, but also our primary health care clinicians and our survivorship clinicians. Documentation has been very low. It's better in early stage cancers and seems to be better from the literature in patients receiving radiation treatment, which was a surprise, and certainly better in certain tumour groups. Again, patients with breast cancer and lymphoma have much better documentation. Factors which improve documentation were clearly centres that have an oncofertility program had better documentation. One study showed the oncofertility program not only increased discussion, but it increased referral, but not the documentation. So it's not just the program, we've got to think specifically about how we improve this. And having navigators and care coordinators with our nurses has also been shown to improve documentation. So here we know it improves communication with our colleagues. It is a medical legal responsibility. There are a growing number of cases about fertility preservation. I've been asked to review 7 cases this year. And we hope the documentation is going to improve survivorship care and follow-up care. So something that we have to get better at doing. So what about the psychosocial effects of infertility? Well, we know that this has a big impact on patients' quality of life, relationships, identity, sexuality, and future plans. The threat of infertility can be quite considerable for patients, and it doesn't always correlate with the extent of the gonadotoxic risk. So the consultation can certainly make a significant difference. It's been shown that patients who just go to see a fertility provider have more hope, have less distress, have more knowledge, and even when those patients haven't been able to have fertility preservation, they feel psychologically they feel better, that they were given the opportunity, they had their voice heard, and felt more knowledgeable also, and sort of the interactions between knowledge and psychological distress need to be unpicked. So what changes psychological distress? Well, we know that there are things that make it better and worse. So things that make it better are clearly support. Those patients who are support experience less distress, fear, regret, and were more positive. And I think Jenna really summarised that really well with her interactions with the team here. What makes it worse? Well, a lack of time, unanswered questions, not being listened to. What do patients want? What can we, elucidate from the literature? Well, certainly there was the need to have more emotional support, and it wasn't support that they just wanted at the time of the fertility preservation. It was the ongoing need to be listened to come back and to be heard, and support making decisions. Who can provide that support? Well, certainly there's a lot of people who can provide support, and I think we heard very nicely this morning that this is a team, and the team often interact with patients in different ways. We have different levels of expertise, and we have different interactions with the patient. So it's really helpful to think about how as a team we can interact better with patients. We are still finding that our patients felt that it was most useful when an oncologist and gynecologist fertility expert was able to provide the support. But psychologists were shown to be beneficial, nurses were shown to be beneficial, and so it's really about developing those pathways and establishing supportive frameworks for our patients. Again, ethical practice of oncofertility care, the literature didn't meet the standards of Prospero and PRISM, but again, it's really clear from the literature there's a number of ethical and legal issues. We needed clear guidance and recommendations. They needed to be updated regularly, and we needed to have a framework for a review of cases when there was difficulties raised by either the clinicians or the patients. So what did we find in the literature about models of care, or those centres that establish models of care? Well, here were the ones that were published, and so it's really clear that those ones that were published had some of the same themes that the patients had felt were important. They had staff who had expertise and certainly had access to training modules. There were resources that patients could have. There was a clear referral practice. There was access to a patient navigator. There was a collaboration across multiple different healthcare professionals. Some were using electronic formats within their cancer prescribing or documentation to identify patients or document patients, and there was access to counselling. What we didn't find from the literature is ways in which these centres validated the work they were doing, what made a good service. And again, this is work that hopefully over time we'll begin to see. So, in fact, before I show this slide I'm happy to send. Human Reproductive Update said that it shouldn't be go out on social media or be shared before, so I'm happy for people to take photos, but the paper's not in publication for another month. So we put all of that evidence together in this infographic, and we've been working with our patients to try and say, well, this is the evidence that we've got based on what you told us. How does this look? We know that these guidelines are available, but does the guidelines reflect how we do things? And I think, that's where the next piece of work was important. These are the things that we have to consider, but how do we do that? And so that brings us to the work on competency. So competency is where a healthcare professional needs to learn a skill and to turn that knowledge into reliable service development and reliable outcomes. So how will oncofertility competencies help us? Well, they would allow our healthcare staff to define how oncofertility care should be developed in relationship to current guidelines. They would outline clearly the competencies that each deliverable that I've shown you as single components, but again in the model of care, should be delivered. And hopefully it will be instrumental in developing and maintaining skills and therefore increasing the uptake and implementation of our services. So the next step that we had was working with a global group was to do a study which was called GForce, and we used a Delphi framework, and we said, well, taking the evidence that the consumers gave us and then taking the systematic review, let's use that to develop a competency framework. So our aim was to define a competency framework, but we also wanted to define the role of individual healthcare professionals, and we wanted to prioritise care into different levels. And by that we wanted to say, well, there's some services that are just starting, there's some services that have been established for a little while, and there's some services that have been doing it for a while. What can we do for each of those services to make them consistent, to grow those services, to get information out, and to be inclusive? And so we had this study only just finished in April, went on for a year. It was a 2-round Delphi. We had the questionnaires translated in 9 languages by a certified Department of Health translator, and then checked by the clinicians and consumers from those countries, and we had 16 countries participate. 4 of those countries were middle income countries. And the initial healthcare questionnaire had 106 statements. So we had our consumer group in Australia look at it, and we also had consumers from these other countries participating look at it, and they developed the patient, well, they're calling it the patient family advocate questionnaire, which only had 93 questions. So they took out questions that they felt that they really didn't have clinical knowledge to be able to comment on, and we set the agreement that we had to reach as 80%, and when you look at the literature, that's pretty standard. And to help people who were doing this questionnaire, we had 9 definitions that kept popping up where they were relevant in the questionnaire. And the questionnaire was online. There was only one country, that was India, that asked for it to be paper-based. And actually what we found, it was interesting, although they wanted it paper-based, it was read paper-based, but then they did the survey online. So it goes to, trying to understand what patients, or what people want in studies is also important. So we had 457 questionnaires completed, 332 healthcare professionals, 125 patient family advocates. 75% of the questionnaires were completed totally. There were 9 questions which did not meet a consensus, so questionnaire 2 was developed, and we asked our participants at the beginning whether they would be interested and willing to take part in the second questionnaire, and 166 said they would at the time, and by the time sort of 6 months went by, 138 said they would and did. So the participation rate was high for this second part of the study. So we know in this start of the study, I'm not going to go through all of the information, but there was agreement that equitable care should be delivered for all patients, irrespective of age, gender, religion and culture. The oncofertility services should be standard practice. They needed to be interdisciplinary. There needed to be a clear referral pathways, and that healthcare professionals needed to be knowledgeable about guidelines and supported to be able to implement those guidelines. In terms of referral pathways, that cancer services needed to have a clearly defined referral pathway, and that process involved the process of referral, but also the priorities for patients, and that was agreed on by both. 85% of patient family advocates felt that fertility referrals should be within 2 days, but that wasn't agreed by our healthcare professionals. And we're going to come back to that. In addition to having a referral pathway, there was an agreement that referral process needed to be clear, that we needed to consider the past medical history and fertility status of patients. And that speaks to these guidelines that while we're thinking about the gonadotoxic risk of cancer patients, as an oncologist, we don't always think about the past medical history and the individual family risk that patient has. So it was really important that was considered, that proposed cancer treatment and gonadotoxic risk was considered, and whether the treatment would change and become more intensive before completion was considered. In terms of consultation, there needed to be a system to identify cancer patients at risk, that cancer patients not at risk should be told that there is no risk of infertility, patients should be given an opportunity to see a fertility provider, and cancer clinicians needed to discuss the risk as well as the medical history. From a communication point of view, we didn't reach an agreement about whether cancer specialists should separate discussion about the cancer diagnosis and treatment with the oncofertility discussion. I guess, that's pretty hard. Cancer discussions have become more and more complex. Cancer clinical trials have become more and more complex. And so we were trying in this section to get more of information from experts and patients about how they wanted us to deliver this information. And in this section, we didn't get agreement. But we did get an agreement that the consultation needed to be sensitive to individual patients' needs, both religious, cultural and family background, that healthcare professionals needed to have an understanding of patients' reproductive understanding, so health literacy, before having those conversations, and needing to identify resources and interpreters that could help with this as well. I'm going to skip over this. So in the second part of this, we were able to get consensus about the roles of healthcare professionals, and I'm only putting this one because I think it speaks really to the papers. So, you know, in this part of the study, there was a real feeling that our nurses had great skills in care navigation that were not being utilised to their full potential, and that all the nurses, both cancer and fertility, that saw cancer patients should have specialist oncofertility knowledge. They should be knowledgeable about referral pathways. They should be the ones providing information about risk. It shouldn't necessarily be the clinicians, and they are often the person who could provide the resources, providing support with information and decisioning and coordination, and also be the person providing support and linking patients to members of the MDT team who could provide more psycho-oncology care. Our GPs, so we had some GPs who took part in the study, and then we went back to a GP cohort who felt that GPs didn't need to have specialist information, but they should have general oncofertility information. They should be knowledgeable about what was available in terms of referral pathways, so that they could make referrals if they were making a cancer diagnosis in the community, and that could start the process early. The coordination of survivorship care was where they felt their role was, and providing support, but also identifying distress and making referrals. And for our social workers and psychologists, again, here the feeling and the more than 80% agreed that our social workers and psychologists should have specialist knowledge. They should be knowledgeable about referral pathways, about supporting patients in decision-making, identifying distress, and again, making appropriate referrals. In terms of the model that we were trying to achieve, this is what it came down to in terms of the agreement that we got from over 80% of those who took part. And I think it nicely gives a picture. It may not be the final picture, but it begins to give a picture of how models of care can start and how they can develop. And so the idea of this is that you go from green to blue to red, although you may be a service that has some red and some green. And over time, there may be some services that span off, so there's 4 or 5 different levels. But really the key essential components were that oncofertility care needed to be integrated for certainly all adult patients as standard care, and that referral pathways needed to be defined. There should be practical support, even if psycho-oncology support wasn't available at every centre. There needed to be clear communication, access to resources, and referral to experts potentially outside of that centre. Whereas when you get to the red, it's the centres that are doing high volume oncofertility work. They're seeing more complex cases. They have full range of psycho-oncology support. They're doing more research. And again, over time, you would hope that all of these centres are doing more research and have embedded frameworks and guidelines. So I think in conclusion, over the last 3 years, we've been able to define the barriers and challenges from a patient perspective, but also a clinician perspective. I certainly believe that we have a lot of work to do still, but it's encouraging that there are some successes against some of the domains in terms of oncofertility care. And I think the infographic demonstrates the number of components that will make the model of care and the complexity, and that we all have a role to play when it comes to oncofertility care. And we can prioritise components of that oncofertility care, and so that centres that have maybe less money, or centres in low and middle income countries, can begin to also develop oncofertility care. And I'd certainly like to be able to thank, we got money to do this from the Kids Cancer Alliance, also got money from the Churchill Fellowship. We have been really pleased to have this work continue with the support of the Australasia Oncofertility consumers, and our Kids Cancer Centre provides the funding for them to travel to Sydney for these meetings, to all the international consumers who reviewed the study and provided guidance, and then all the patients, parents and colleagues who participated, and then a really big shout out to all the G-Force investigators. It's really hard when you're in different places and different timelines. We had to have 3 different teleconferences at different timelines to get everyone in on the calls, but I think it was really worth it. And the next phase for us is trying to implement these competency frameworks and see whether, we've got it right.